Hey folks, Dr. Steve Garber here. Welcome to the first online Cox Flexion Distraction Technique Lab. I wanted to compliment you on your decision to take this class. I think you'll find it a valuable asset that complements all the other wonderful techniques that you have learned during your stay here at Life University. So what is Cox Technique? Well, the essence of Cox Technique, also known as flexion distraction, is the reduction or elimination of non-pathologic neurocompressive lesions of the spine that are either discal or non-discal in origin. So let's break that down a little bit. When you have a neurocompressive lesion that is causing deterioration in the sensory and or motor system, sometimes we can only reduce its effect. We cannot always completely eliminate it, and that's true in the medical realm as well. Once Wallerian degeneration has set in and permanent nerve destruction has occurred, we're limited in what we can do, but nonetheless, we can assist somebody who's trying to avoid surgical intervention with a conservative approach to their problem. Now, on the other hand, at times we can completely eliminate the lesion, the neurocompressive lesion, and help to restore the patient's health back to 100%. We always deal with, of course, non-pathologic lesions, and those may be discal in origin, so we might have a herniated disc of its different forms, and we'll go over all of those forms as we progress in the class, but we have protrusions, prolapses, we have extrusions, we have sequestrations, we have free fragments, so on and so forth. And of course, Cox Technique is effective with all of those, but we're also very effective with musculoskeletal spinal disorders that are non-discal in origin. So we're going to show you some wonderful really gentle methods to approach the spine for facet issues and for spondylolistheses, for scoliosis, and a broad array of other different spinal disorders as well. So I think you'll find this is a wonderful technique, again, to add to all the other fine methodologies that you've been learning during your stay here at Life University. A good friend of mine, Dr. Paul Markey, who is also very, very proficient in Cox Technique, made this statement, and I'd like to dissect it for you because it's really important. Paul states, "He who controls the motor signs controls the case." So let's break that down. With any neurocompressive lesion, you have the potential of deterioration in the sensory and or motor system. And what Paul is stating here is that if you can effectively treat, control, and improve the motor signs, then you can accept that case, and you can be a positive force for that case. But if the motor signs begin to deteriorate, then we have a case that we might need to get assistance on. So the question is, why motor over sensory? Well, think about it. If you had the choice of sensory nerve damage or motor nerve damage, which would it be? Well, I hope you would say sensory. See, with sensory nerve damage, you might have some ongoing permanent numbness in a patch or an area of the lower extremity. But with permanent motor damage, you might actually have foot drop, which is a life-changing or life-disabling disorder or condition. And it can even be worse than that. We can be dealing with either bowel or bladder denervation when we have extreme deterioration within the motor system. So whenever you do a neurologic assessment on a patient, we always carefully check sensory and motor, but we want to highlight that it's really important that you keep an eye on the motor signs and make sure they're not going south, make sure that you are effective in treating them. If you feel they are deteriorating, don't dismiss the patient. Just get a trusted ally in the medical field who'll do an assessment for you and maybe co-manage the case with you. And we'll talk about that more as we progress along. So what is the technique? Well, it is an adjustment. It is not traction. It's certainly not listed in the CPT codes as a form of traction. It is an adjustment. And what distinguishes it from other adjustments is that it is done under traction or distraction. The definition of distraction is the separation of two opposing joint surfaces. And so, excuse me, in the case of distraction of the spine, we're separating two vertebral end plates, and what sits between the end plates is the disc. And so we have a profound effect on the disc when we do this. But the technique actually allows us to mobilize, improve, and restore the physiologic ranges of movement to any vertebral motor unit or functional spinal unit, however you understand that concept. Okay, back in 1997, National College and Loyola Medical School, along with Dr. Cox and primary researcher Ram Goudavali, did the first federally funded research study on Cox Technique, and it pretty much put Cox Technique on the map. In general terms, we're an under-researched field. There's only 3 techniques that have any federally funded, peer-reviewed, journaled research, and that's Cox Technique, CBP, and Activator. And even with those, the technique is slim. It's because it's costly, and most of these methods are underfunded. They just don't have the money to do the research. But what did we find out in 1997? We're actually going to direct you in the future to a 10-minute video that shows you exactly what took place during this research. But we found 4 things occurred when flexion distraction was done properly to a functional spinal unit. Number 1, we found there was a reduction of intradiscal pressure, which is wonderful because during any acute lumbar or cervical or thoracic spine disorder, you have a great increase in intradiscal pressure, putting pressure on all the neurologic structures in the area of the IVF, better known as the osteoligamentous canal. That's what researchers refer to the IVF, or the IVF zone. Some refer to it as the neuroforaminal space. Anyway, the second thing we found out is we do get an increase in intervertebral disc height. So it does actually, we have proven or shown that when we decompress, we do separate the vertebral end plates at the vertebral level being treated. Number 3, we get an increase in the IVF size. So that neuroforaminal space where the nerve roots are exiting from the cauda and out toward the IVF, if there's any compressive forces in that area, it will help to decompress. And then number 4 is we can restore facet joint physiologic ranges of movement, which is wonderful because that in essence is what an adjustment does. When you do a P to A thrust on a vertebrae, the effects of that thrust is to restore physiologic ranges of movement. So this is a gentle way of doing that. Disc pressure has been studied in numerous research endeavors. This is one study by Nachemson. This was done in the late 70s, and what they did is they took research volunteers from a medical school who were willing to have a transducer on a needle, on the tip of a needle, inserted into the 3rd lumbar disc, and that transducer had the ability to measure the pressure within the disc. and they did it at the L3 level, and then they had the research subjects assume a multitude of different positions, and what they found that disc pressure varied from 25 millimeters mercury to 275 millimeters mercury pressure. And we'll be discussing that study as we progress along with the course. We are fortunate to have two of the genuine article Cox Generation 8 tables, a wonderful piece of equipment. They are handmade in a factory in Michigan, and it is a very fine-tuned machine. Nonetheless, quite pricey. They're about $18,500, so not something you're likely going to jump on right now. But if you do want more information on the table, if you'll just plug that into your browser, it'll give you all the information that you would like for the present or for future reference should you get to the point where you're ready to purchase one. This slide labels all the major functions of the table, so it'll give you something to refer back to once you've seen the table in real time. But of course we have the cervical headpiece, and we'll be spending time on that towards the end of the course. About 90% of the course is geared toward the lumbar spine, and of course this is the caudal section of the table where all the magic occurs for treating lumbar spine disorders. Here we have the control panel, and the control panel is really for the automated functions of the table. So that this table can be used in an unattended fashion without the operator in the room, creating automatic y-axis decompression, but that's in the more advanced realm of this technique and not something we'll be getting into, at least not this quarter. We've got the tiller bar over here, and we're going to go over that in detail real soon. And the tiller bar is where you can control all the manual functions of the table. And here we have the tiller bar. The beauty of this table is that all the manual functions can be controlled through the tiller bar, making the table quite easy to use and giving you everything you need for any single patient available at just the touch of a button. Top button switches between auto and manual mode. We mentioned that for all good purposes we're going to be keeping it in manual mode, and you can see the light is illuminated, indicating that it is in manual mode. The next two buttons control the tension of the caudal section, which is adjusted for the patient's weight so that the table is very easy to use. As a matter of fact, if set properly, we have what we call a power balance. The table is completely balanced and can actually be used with just a touch of a finger. Not that we're recommending that. We recommend you get your hand, on the tiller bar or the tiller ball, but it is so well balanced that you could actually use one finger. And then the column height is adjusted through these two buttons. So the actual vertical height of the table goes from 24 to 30 inches, and the table will rise if you hit the top button, and then it'll lower if you hit the bottom button. There. Okay, to get into a little detail, if we look at the control panel, the lights to the right give us an idea of how much spring tension is in the caudal section. And that needs to be set properly before the patient gets on the table. And this is how it's done. Of course, we put the table in manual mode, and then for an average patient, which we'll consider as someone between 150 and 200 pounds, we want to set the light to number 5. Okay, All right, and then for every 25 pounds of mass of the patient, either up or down, we're going to go up one lighted position. And that would make a lot more sense once we get to a table, and hopefully we can shortly. All right, an interesting concept known as hoop tension. You actually were born with a lumbar support that can be activated by contracting the transverse abdominis muscles in the front and the glutes in the rear. You can read a little bit on that slide about it. There's a picture of the transverse abdominis muscles, and if you look at those, they almost look like an internal corset or support. But hoop tension, the concepts are wonderfully displayed through looking at the snake. And of course, as the snake kind of wiggles from side to side, you're going to get movement of the vertebrae as demonstrated in this diagram. But if we form a hoop of tension around a group of vertebrae, those will remain fairly stationary. That's known as hoop tension. Another concept of hoop tension, if it helps you, are these whiskey barrels. And those whiskey barrels are made out of finely honed wood slats that fit very nicely together. And then those are compressed through these stainless steel bands. That's actually what holds the wood close enough together so no liquid leaks out. And of course, they don't use glue or staples or screws, because as the wood becomes moist or wet, the glue, of course, would get into the liquid and ruin the whiskey, and then the metal taste would also get into it if you use staples or screws. So that barrel is completely held together through the tension applied by those bands. And of course, if we took those hoops off, that barrel would just fall apart. Okay, so when a patient is in an acute situation, in other words, they have an acute lumbar spine disorder, they're typically having trouble ambulating, and they're certainly having trouble getting in and out of beds, in and out of cars. And of course, they would have trouble getting on and then off of your adjusting table. So we teach them the concept of hoop tension. And in order to create hoop tension around the lumbar spine, we ask the patient to very simply pull their navel deep into their abdomen and then squeeze the buttocks together. And just hold that as they descend down on the table. And that will act in a similar fashion as we see the hand around the snake. It will stabilize the lumbar spine, minimize movement, and make it easier for the patient to get on and off the table. And we will be demonstrating that in real time once we have the opportunity to do that. Okay, so let's start to get into the concepts surrounding the technique. Let's start with line of drive. For 99% of all procedures, actually there's only one exception, the line of drive is 2/3 I to S, 1/3 P to A. The table, in a sense, acts as a fulcrum, while your contact on the spinous process is a lever. Of course, if we look at this example, we see a heavy boulder that the farmer would never be able to move if he did not have the fulcrum and the lever. So with the proper equipment, we have all the forces necessary to very gently decompress any vertebral level within the spine. And here is a picture of a practitioner getting under a spinous process, and then you can see the forces of decompression as demonstrated in the diagram. Tissue pull is always made in an I to S direction. As you can see in this example here, the practitioner is sliding in an I to S direction off of the L5 spinous process and nuzzling up under the L4 spinous process. The contact point on the doctor's hand is the softest part of the thenar eminence, which is demonstrated over here. And then the segmental contact point is always the spinous process directly above the involved disc. So as you see in this example, here we have the L4 disc, and if we wanted to decompress that disc, we would get on directly under the inferior aspect of the L4 spinous process. If it was an L5 disc, which we don't quite see, we can just draw one in there. If we were trying to decompress the L5 disc, then we would get right over here under the inferior aspect of the L5 spinous process. And we'll get into this in more detail as we progress along in the course. Okay, the barrier of elastic resistance refers to a concept of tissue tension, and learning to feel tissue tension is essential to mastery of this technique. Barrier of elastic resistance is basically the initial tension point that you're going to be looking for any of the procedures, tolerance testing, protocol 1, protocol 2, so on and so forth. And it's basically the point where the soft tissue elements at any individual functional spinal unit are fully taut. So all the tension is out of the ligaments, the capsules, the muscles, etc., and etc. It's basically what we refer to as preloading the segment prior to treatment. As a better concept to explain the barrier of elastic resistance, we're going to explain the three physiologic ranges of motion. We're not talking about the anatomical ranges of motion, which are basically flexion, extension, right lateral bending, left lateral bending, right rotation, left rotation. We're talking about a different concept here. These are the physiologic ranges of motion, and it starts with active. So every single joint in your body that can be moved through the action of voluntary muscles has an initial active range of movement. So if you were to take just your index finger and flex it forward as though you were like trying to make a fist, the furthest you can flex it forward, that would be your active range. Now if an examiner were to come along and move it a little further, then that would be your passive range. And where the examiner cannot really go any further, he hits a barrier, and we call that the barrier of elastic resistance, and that is demonstrated by this red line right over here. However, if you go past the barrier of elastic resistance, we get into a really small joint space known as the paraphysiologic joint space. And that's basically where adjustments occur. So when let's say you're doing a supine cervical adjustment to somebody's C5 vertebrae, you have to take them through the active and the passive range to the point of tension, which would be that red line. And once you are at that red line, if you give a quick thrust or a quick impulse, you'll get joint cavitation, or the sound of manipulation, and you will have entered the paraphysiologic joint space. So the barrier of elastic resistance is between the passive range and the paraphysiologic joint space. Flexion distraction, just like any other adjustment, exists in the paraphysiologic joint space. There's one other range that we want to help you to prevent from going into, and that's known as the limit of anatomical integrity. And going into that range would create tissue failure. It's what we call the sprain zone. So like with any adjustment, if delivered in too aggressive a fashion or in too deep a manner, you can actually get some pain or discomfort and possibly even sprain the area. That can occur with flexion decompression as well. And so we're going to show you in real time eventually how this all works, so that as to prevent any exacerbation of the patient's condition. So if we look at this in somewhat real time, the three lumbar spine physiologic ranges in flexion, we just take flexion as an example. All right, so here is someone actively bending in flexion. And if we were to take a look at L4 and L5 vertebrae, you can see there's actually about 13 degrees of movement on average between L4 and L5 in the flexion realm. So that's the active range. Okay. Now, if an examiner comes along and gets under the L4 spinous process and pushes it further into flexion, that would be the passive range. Once he reaches the end of the passive range, there's a barrier, and that would be the barrier of elastic resistance. If he could push past that barrier, he will enter the paraphysiologic joint space, create joint cavitation, and mobilize the joint. We're going to show you how to do that in a gentler fashion through utilizing the Cox flexion distraction table. Another concept surrounding flexion distraction is the concept of joint play. What is joint play? Well, basically, joint play are intrinsic movements within every movable joint of the human body that cannot be produced through the action of voluntary muscles. However, the health of the joint is very dependent upon these little movements. The easiest one to demonstrate is long y-axis of the metacarpal phalangeal joint. So to the left, we see the metacarpal phalangeal joint at rest. There's the two surfaces of it. This is the proximal surface and the distal. If an examiner were to come along, as we see in the arrow here, and pull the joint in a y-axis fashion, we see an increase in the separation of the joint space, and that is joint play. This movement cannot be produced through the action of voluntary muscles. There's nothing you can do to elongate your finger. Flexion decompression of a vertebral segment is similar. You cannot elongate or separate the space between two vertebral end plates. It would have to be done manually through the use of proper equipment. One possible way that it could be done by yourself is through getting on an inversion table where you turn yourself upside down, and then you would get general full spine traction. So in other words, each segment would separate to a certain degree, but with our technique, we're going to show you how to focus all that force onto one vertebral level.
This shows the computer animation of the flexion distraction procedure. This was done using Autodesk 3D Studio software and viewpoint geometric data. Virtual table and virtual patient and the spine are animated. As the table is moved down, the joint is distracted, creating a facet gapping and movement. Here the movement is shown exaggerated.
Okay, so the previous slide was Dr. Cox himself narrating an animation that was done for a video of their 1997 research project that we have slightly touched on already, and we'll touch on more during the lecture part of this presentation. But let's go over that video kind of in real time and one step at a time. Of course, here we have a simulation of the flexion distraction table, and then of course there's a patient. And this would be the L4 vertebrae here. And this would be the L5 vertebrae here. All right, the blocked or stabilized vertebrae is that segment where your contact hand, or the thenar eminence of your contact hand, is directly under the inferior aspect of the spinous process, as we see by the checked arrow. So in this particular example, L4 is the blocked or stabilized vertebrae, and of course the goal of the practitioner is to stop all movement at the stabilized or blocked vertebral level. Then as the table descends, right, so as the table makes its descent downward as such, the vertebrae directly under the block segment will go into flexion decompression, and then the disc between the two would be decompressed. So that's somewhat of a real-time explanation, and we certainly will elaborate on that once we get into the lab, where you can see it demonstrated in real time. Okay, folks, this slide is in there to demonstrate the subtlety of this technique. Many doctors who are untrained have Cox or Cox-like tables and unfortunately do not perform the procedure as it should be done or as it's taught by the Cox people themselves. So this chart is from Greaves' Modern Manual Therapy, and it shows the general range of movement for the two most common vertebral levels that we will be treating, and that's the L4, L5 right there. Average is 13 degrees of flexion at that segment, give or take 4 based on the sample of those tested. And then the L5S1 is 9 degrees, give or take 6, again based on the sample of people that they were examining. It is an extremely subtle technique, and once you get to the barrier of elastic resistance, in general terms, the caudal section of the table should not descend any further than about another 2 inches. And of course, that's just a simple representation, not accurate. It's not measured specifically, but it's just to make a point that 2 inches is a small excursion. And then if we look at degrees of movement, again, we've got 13, L4, L5, 9, L5S1. We can average that off to 10 degrees. We can see 10 degrees of movement, as demonstrated by this chart, is not a lot of movement. So if you see someone using this equipment and taking that caudal section of the table and using it like they're trying to prime a well pump, they are not using it properly, folks. And it is actually easy to exacerbate a case with this equipment if you don't know how to use it. Okay, so that's the concept of that slide, just to kind of give you a view as to the delicacy and the subtleness of the technique. Okay, the next two slides go over what we call the clinical preparation sequence. Basically, we have to prepare the table, prepare the patient, and prepare the doctor so that treatment is maximized and done in an efficient and accurate manner. And there actually is a video that goes over all of this, and there will be a link in your assignment section to that video. But just to go over it verbally, let's move to the next slide. Okay, so with table preparation, we always check and make sure if there are drops on the table that they're not activated, because that would be very jarring for the patient to try and mount the table and all of a sudden have a drop release. We also make sure that the caudal section is secure. So in other words, the brake that releases and then once again locks the caudal section, that brake needs to be locked. And then we ask the patient if they have a preferred height, which they will, and you can show them how the table elevates, and just let them choose a height that suits their condition or their pain. And then you ask the patient their weight, and you set the spring tension according to their weight. And again, that is demonstrated on the video. Then we prepare the patient. We can't do this over clothing. Absolutely impossible. It's hard enough to get and maintain a contact directly on the skin. So we have the patient completely remove their belt, loosen their garments so that we can lower them to an appropriate point where we're not hampered by the garment. We instruct the patient to stabilize the lumbar spine by creating hoop tension. And so in other words, we ask them to pull their belly button deep within their abdomen, tighten the buttocks, and then mount the table. Assist the patient only if they want it. Most patients would rather do it on their own because of the pain level. They don't want for you to accidentally move them in the wrong direction. We then, once the patient is down on the table, we find their ASIS, and we position the ASIS 2 inches superior to the inferior aspect of the thoracolumbar cushion. We then adjust the ankle rest to create slight plantar flexion of the feet, relaxing the calf and hamstring muscles. We then adjust the tiller bar to your particular wingspan, and the tiller bar has a numerous amount of adjustments to make it so that you, the doctor, have greatest of ease in decompressing the patient's spine. We then get the patient's permission to expose their lumbar region and their back. We properly stabilize the caudal section before releasing it, and then we check the spring tension and fine tune it so we have what we call a power balance. And power balance is basically where the table is in a vertical level or neutral position, and when you push it down, it goes down easy, and it comes up without having to pull it up. And again, that's demonstrated on the video. And then the doctor preparation. You position the height of the table or the top height of the cushion at about your mid-thigh area, and then you position yourself directly squared to the side of the caudal section, placing each one of your thighs on opposite position of the patient's knees. You basically, if you're facing the patient's right knee, your right thigh is slightly superior of their knee. Your left thigh is inferior of their knee in a fairly wide stance. And then you extend and lock your superior arm at about a 30 to 45 degree angle, locking your shoulder, elbow, and wrist, and basically using that arm as a lever, as we had described in an earlier slide. Your arm is the lever that's contacting the vertebrae that needs to be decompressed. And of course, this will make a lot more sense when you see it on the video or in real time. All right, the first procedure that we're going to teach you is called tolerance testing. And of course, we have this nice little quote, which is many use and has been attributed to Hippocrates, and that is, "First, do no harm." Anything, including a butter knife, can do harm if used improperly. And that includes every adjustive procedure as well. If not administered properly to the patient, it can do harm, and that certainly does include Cox Technique. And so we want to make sure that that is avoided. So we use a procedure called tolerance testing. Tolerance testing is on video. There is a video link to this procedure, and again, the link to that is under your weekly assignment for week 1. But basically, this is not a treatment procedure. This is a preparatory and an investigative procedure. So basically, prior to utilizing Cox flexion distraction or using the table to perform distraction, the patient's tolerance level to the procedure is checked and then well documented. And this gives you what we call a treatment start point. And of course, everyone is going to have a different one based on the severity of their condition and their pain tolerance level. There's 3 phases to tolerance testing. You have central, lateral, and then central repeated again with the restraints, the ankle restraints or the cuffs on. And basically the goal of tolerance testing is to find this treatment start point. And in finding the treatment start point for any individual patient, we're going to answer 2 questions. The first one is, can they handle the addition of the restraints or not? The restraints do add about 50% more traction force to the area being distracted. So that we have to find out, can we handle those, or can the patient handle those? And then the second question is, how much pressure as applied by the practitioner or by the chiropractor can the patient handle on the involved segment? Do we have to use a very light? Can we use a medium or even a heavy amount of pressure? And so that is the goal of tolerance testing. And again, click on the video link and watch it. It will make a lot more sense when you see it done in real time on video. All right, this slide is nothing but a written narrative of the steps that would be applied for central tolerance testing. Again, refer to the video. And likewise, this is a written narrative for the lateral tolerance testing. Again, refer to the video. And finally, this is a written narrative for the central tolerance testing with the cuffs on. And once again, refer to the video. Okay, here we have a few clinical tips. So when we're doing tolerance testing, of course, we're inquiring of the patient that for their level of pain. Now, obviously, they're already in a lot of pain, but what we don't want to do is add to that. Okay, so as we're testing them and we're inquiring for pain or asking the patient if the procedure is provoking or increasing their pain, we're basically asking them if it is at an intolerable level or if something new or different is possibly happening to their leg. So maybe as you're doing it, they're saying, you know, doc, as you're doing that, my leg is starting to tingle, or my leg is starting to burn, or my leg is going numb. All those indicative of too much decompressive force, or the patient is possibly at a point where they cannot tolerate the procedure at this present time. Okay, so if the patient does fail this tolerance testing procedure, there's two options. And when we say fail, in other words, you can't find a level of decompression that's tolerable to the patient without increasing their pain in the back or causing some symptoms in the leg. If they do, there's two possibilities. One is a procedure that we'll be teaching you later in the quarter, and it's a variant of our first protocol for treatment called Protocol 1 variation, and it's actually an simile of the standard Protocol 1 that's done with the patient on their side, and we'll certainly be getting into that at a later time. And then, of course, if that doesn't work, you would have to send the patient home for complete bed rest and through the application of ice and some gentle exercises until they've gotten to the point where they can tolerate the procedure. One other possibility is to co-manage the case with a friendly orthopedic physician who's willing to do that. Someone who can possibly prescribe a pain reliever or maybe a Medrol dose pack, which is a steroid dose pack. That's certainly going to be up to you and based on your ability to find somebody who would like to work with you for the benefit of the patient's welfare in treating these conditions in a conservative fashion. And these are 5 common mistakes that are done that would actually create an exacerbation of the condition instead of helping the patient. One would be too much pressure applied by the contact hand. One would be too much depth applied to the caudal section, right? We mentioned about 2 inches. If you go way beyond that, you are going to pass the paraphysiologic joint space and go into the sprain zone. 3 is contacting the incorrect vertebral segment. I guess that would be analogous to a surgeon cutting off the wrong leg. Well, not quite that extreme. Number 4 is applying decompression below a neurologically compressed lesion. So in other words, we have to stay above it. So if it's an L4 disc, we have to stay above it by getting on the L4 spinous process. If you get on L5, it's going to actually further compress the lesion by putting pressure directly up under the protruded disc and the compressed nerve root. That make a lot more sense when we explain it in real time. And then 5 is distracting beyond the patient's comfortable tolerance level. Right, and that's why we do tolerance testing, is to find out exactly what they can tolerate and to keep it there and no further. And of course, as they improved, then we would use greater levels of decompressive force to continue to assist the patient in their healing process. So those are the 5 common mistakes that are made in utilizing this procedure, and we'll go over all of those in real time eventually. Okay, and the final slide for this lab is just some important notes concerning the distraction procedure. We're feeling for a spasm, of course, as our contact hand is contacting the vertebral segment that needs to be compressed. Of course, the rest of our hand is laying flat on the patient's lumbar spine musculature. And as you're doing the decompressive procedure, the flexion decompression, if you feel the lumbar musculature go into spasm, then you are applying too much decompression. Even if the patient is not complaining, that's still an indication that you're applying too much decompression. So you need to back off through either applying less pressure by the contact hand or less depth through the tiller bar hand. Another interesting phenomena that we're not exactly sure of is interscapular pain during the decompression procedures to the lumbar spine. And you'll periodically run into this while you're decompressing the lumbar spine. The patient will tell you, Doc, I'm getting a pain between my shoulder blades. All that indicates is that you're using too much decompressive force in the lumbar spine. And you'll find if you'll back off a little, that will immediately go away. So as you're doing it, the patient almost feels like they've got a catch or like a little stabbing or deep aching pain between the shoulder blades. And you back off a little and ask them if it's still there, and they'll tell you no, it is not. So again, keep those little tidbits in mind.